Welcome everyone this morning to Academic Half Day. Lindsay and the other chief residents are in a meeting this morning, but will be joining us shortly. So this morning we are truly honored to have Brock Gaster talk about a very important topic to us. He is an attending at the Roosevelt Clinic, and many of you work with him there. But where you may or may not know him is as really a national expert on this topic of primary care and dementia and advanced care planning in particular. And we want to invite him back here to talk and share his thoughts about how to do this for all of you. So thank you, Brock.
All right, no, thank you so much for having me. And it's really, it's a pleasure to come and give you just a brief overview, which is really intended as a very, very practical. This is a practical presentation, really about how to think about diagnosing and managing dementia. And it's very much in the sort of internal medicine setting. So really making the really solid point that this is so much an internal medicine disease rather than a specialist disease. And we're going to talk a little bit about why. And so, as John mentioned, I'm a primary care doctor, but have been really focusing for about the past 7 years or so on dementia in terms of how to really do this sort of efficiently and accurately, and happy to give you that quick overview. And so I want to start out a little bit thinking about why is this such a hard disease to think about? And so much of it is that the diagnosis especially in its early stages, can be tricky. Like there's definitely uncertainty. We're used to lots of uncertainty in medicine, and this is definitely one of those situations where the early stages of cognitive impairment can be difficult to sort of detect and measure, and yet it's so important because we really can intervene in meaningful ways if we identify it early. And and it's just psychologically hard too. I mean, this is a topic that our patients are sometimes very happy to sort of ignore that it's happening, and it can be tempting to skip over it. But really, we can make such a difference by identifying it early. It's really better care, and the key focus of that better care is improved communication. So when our patients are slowly developing cognitive impairment and nobody is really acknowledging it or putting it in the chart, there is tremendous risk of bad communication where patients are out there isolated, not getting the support they need. And so by making a diagnosis early and bringing family members in sooner, we really can improve the work that we do. It can be easier to do our work, to have family members involved. And as John mentioned, a really big focus of my work is on advanced care planning. And so we're going to talk at the end of this session about how this can really improve setting goals of care, aligning care with this major thing that's happening in people's brain, which is really in so many ways providing better care. We're going to talk about connecting to community resources, and then really the big hook is the proven interventions that we can make to improve brain health. And two of the biggies are treating sleep apnea in people who are experiencing cognitive concerns. Treating hearing loss in people who are experiencing cognitive concerns really can make a difference in people's brain health. So everybody is aware that dementia is a big deal right now, but really the big point is how much of a growing problem it is. So that there are these solid projections that really in the next 10 to 20 years, as the baby boom cohort enters solidly into that age range of risk of Alzheimer's disease, that the number of people living with dementia is expected to double in the next 20 years. And so as hard as we think this is now, it really is going to become much harder in the coming years. And so it's really such an important value in getting better at identifying and managing this disease. I mean, the baby boom cohort is really the generation that is probably going to live longer than any other generation in history. And so more of them, as we are getting better at treating their heart disease and getting better at treating cancer, that more people are going to be living into that age range, and there are just so many more of them. And so really we can sort of we can do this better. We need to do this better because there is such a sense of this silver tsunami that is on the way. And so here's the three main parts of my talk today. We're going to talk about making a diagnosis of cognitive impairment, setting a plan for a newly diagnosed patient, and then ending with managing dementia as it progresses. So let's start with diagnosing cognitive impairment. And it's really how to perform a cognitive evaluation in the general internal medicine setting, how to identify contributing and reversible factors that you really can fix, and thinking a little bit about the difference between the diagnosis of mild cognitive impairment and the diagnosis of dementia, because they really are different, and we're going to talk about that. So let's start with a case, an 82-year-old woman who's in your office for a wellness visit. She's generally very healthy. She has high blood pressure and arthritis. She takes losartan, occasionally some ibuprofen, occasionally some Ambien, and she happens to mention to you, I've been worried about my memory. And so common scenario question is, what should you do? You might be tempted to reassure her and say, oh, don't worry, this is normal to get more forgetful with aging. You might be tempted to just immediately place a referral to the Memory Brain Wellness Center at Harborview, referring her to a neurologist. You might be tempted to stop everything right then and there and try to do a 15-minute cognitive assessment, and then kind of blow up your whole schedule for that clinic session. Or you might offer her a cognitive evaluation, a longer follow-up visit, ideally with a family member or close friend present, and really say, gee, that is possibly worrisome, but I can help. And so that is the right answer. And so it's really three situations where this might come up. And so really being aware is that first step. So a patient or a family member might mention a concern. Really, maybe the most common scenario this might come up is where on that annual wellness visit questionnaire, so that crazy long questionnaire that patients are required to fill out for a Medicare annual wellness visit, there's a question on there about, do you have concerns about your memory? And it is not too uncommon that someone will circle yes. And, oh my God, for years, I was like, what do I do when somebody circles yes to that question? I really sort of, what really led me into work on this topic is really not knowing what to do. And so here's what we're going to talk about what to do when somebody circles yes to that question. But it really also might be just anyone in your clinic, your front desk staff, your medical assistant, or you might notice that a patient who always used to be on the ball is starting to get confused about appointments, confused about medications. And so really any of these three situations are the key scenarios to be aware of this potential problem. But you're not necessarily going to immediately leap to do a full cognitive assessment on every single person who circles yes to that question on the Medicare Annual Wellness Questionnaire. You're going to want to have a decide step. So there's the be aware step, and then there's the decide step, where you want to have three questions to help you decide who needs a full cognitive assessment, because you really do want to take a moment to try to assess whether is this a worrisome sign that somebody is having, or is it somebody having the sort of normal concerns that go along with normal aging. And so the three questions that I recommend trying to sort of have handy are forgetting something that just happened. So that's a worrisome sign. So somebody who is repeating the same story or asking the same question 30 minutes later needs a full cognitive evaluation. Somebody who is experiencing difficulty doing a complex task that used to be easy for them. So somebody who used to be able to make a complex recipe with barely even looking at the recipe, they just sort of had it in their head and they could sequence those events, who's now suddenly getting stuck and unable to do that. That is a worrisome sign. Somebody needs a full cognitive evaluation. Somebody who finds themselves unsure of where they are in a place that they've been to often That kind of disorientation is a worrisome sign and really requires a full cognitive evaluation. And and that's really to be distinguished from normal situations, normal concerns that somebody has, like oh, I'm finding I'm misplacing my keys more often, but then I find them. Not worrisome, much more consistent with normal aging. Or somebody saying, it's taking me a little bit longer to sort of come up with somebody's name. Not a worrisome sign. That's normal aging. And so truly to help in that sort of decision point, it really is important to have those three questions. And so here are the sort of ways that we have built those questions into the UW Medicine instance of EPIC. So there is an EPIC dot phrase that is dot cognitive quick questions. So if you just type dot cognitive, it will pop up. It's that dot phrase is embedded in a new EPIC smart set that is called cognition. So if you search for the smart set cognition, you will find this dot phrase in that smart set. You can also go to our website, cognitionprimarycare.org, and find these three questions. It's a one-page paper form that a medical assistant or a provider can give to patients. And here's what that one-pager looks like. It's a quick questions if memory is a concern, which again, you can either download from the website, or you can find it as an EPIC dot phrase, or find it in the EPIC smart set. And it really asks these three questions, and really a yes to any one of these three questions is really a signal that you really do need to strongly encourage a full cognitive evaluation at a follow-up visit. And then at the bottom of that page, it really also lists those three things that are less concerning, that are more consistent with normal changes that happen as people get older. So if a dedicated cognitive evaluation is warranted, the biggest sort of pearl is you want to so strongly encourage a family member or close friend to come to that visit with them. It's not uncommon that people come to a primary care visit by themselves, but you really, even the very best dementia experts cannot really accurately assess somebody's cognition without an observer there who's able to contribute to the history taking to say how the patient is doing as they navigate through their lives. So you really want to say, I really would like to have you come back for a cognitive evaluation, and it is absolutely essential that a family member or a close friend, somebody who spends a lot of time with you, comes with you to that visit to help with that assessment. This works much better as a longer visit if possible, and it is such a big step forward in 2021 that actually the RVUs that are paid for a level 5 visit are actually double now what is paid for a level 3 visit, and that this can also now be billed as total time if you're attending. So sorry that this is less accurate for a resident visit, which can't necessarily be time-based, but really for in a good sort of general rule of thumb for you going forward in practice is that a level 5 visit only requires 40 minutes spent total on a visit, which includes time prepping and charting of that visit. It's no longer just face-to-face time for that time-based billing. Regardless, the most important point is, in addition to having a family member come with them to that visit, if you can manage to schedule that visit as a long slot appointment, you will do a much better job doing that cognitive evaluation. So these are the three parts of that cognitive evaluation visit. You're going to use a checklist of reversible causes and other factors that you can fix. And again, that's in the dot phrase, dot cognitive checklist. You're going to get input from a family member, and you're going to assess their cognition, ideally using a Montreal Cognitive Assessment Test of MoCA test. So here's what that cognitive checklist looks like. So there's the easy labs that you you are already well aware of. This is like one of the key things that they teach in medical school about cognitive impairment, is how important it is to make sure that you're not missing B12 deficiency or hypothyroidism as definitely causes of cognitive impairment that are reversible. Look at their medication list carefully. You're really looking for sedating medications or anticholinergic medications that can impair cognition. So oxybutynin for urinary incontinence is one of the most common ones. One that you're going to need to ask about because it's an over-the-counter is diphenhydramine, Benadryl, which is in Tylenol PM. Lots and lots of people take this to help them to sleep at night without a prescription. You're going to need to ask about it, and really making the point to people that, gee, if you're worried about your cognition, I really do think we could help your cognition by staying away from this potentially very harmful medication that might be impairing your thinking. Benzodiazepines impair cognition, and Ambien, so Zolpidem, impairs cognition, not just sort of in that kind of immediate morning after hangover, but really in a consistent sort of ongoing way. Somebody over age 75 who's taking even occasional Zolpidem is going to have cloudier thinking. Similar idea with alcohol. So somebody might have been perfectly able to have 2 to 4 drinks a night, and it never really impaired their functioning. It never really was an alcohol use disorder. They were perfectly functional in their use of that amount of alcohol. But as they move into their 70s and 80s and are starting to sort of report some cognitive concerns, you can tell them that, gee, that amount of drinking might have been perfectly fine for you when you were 55, but now that you're 75, I'm really worried that that amount of drinking is really sort of impairing the health of your brain, and reducing your alcohol intake to 0 to 1 drinks a day instead of 4 to 5 drinks a day will help to keep your brain healthy. And then again, these comorbidities that really can sort of impair cognition if they are untreated or undertreated, so important to ask about and think about: sleep apnea, hearing loss, and depression. And that checklist is in a dot phrase in Epic .cognitive checklist. If you just type in .cognitive, it'll come up. And again, this smart phrase is embedded in the cognition smart set. And so there's what that Epic checklist looks like. It asks you to go through those careful things. It asks about visual hallucinations, which is a tip-off to Lewy body dementia, which we're going to talk about later in this talk. It reminds you to perform a MoCA test. It reminds you to obtain input from a family member or friend, and it's going to bring in the patient's last B12 and TSH to help you to sort of identify, is this something that you should definitely be checking again right now? It's a really sort of slickly designed checklist. It's got a dot phrase. It's got vanishing tips in it that remind you why to ask any of each of those questions. And those are vanishing tips that will disappear once you sign your note. Dot cognitive checklist. And here's what the smart set looks like, that smart set called cognition. And so it's got each of these dot phrases embedded in it, and is really, really handy, easy to favorite in your Epic user profile.
Brock, I'm going to ask, just because I know that there's a number of residents on here who are VA based.
Yeah.
If you have information, if there are similar tools for VA based residents.
You know, I don't know, and I apologize for that. I always forget the VA audience, which I support you, and I apologize for not sort of tailoring this more towards you. And I'm not sure what is in the VA electronic health system. You know, I definitely, one of the big goals of my program is to start with the UW Medicine instance of Epic, but really create easily shareable tools like this that can go to other instances of Epic, like at Valley Medicine, as well as to other health systems like the VA. And so sorry that I don't know off the top of my head what's available there. But you can go to our website, cognitionprimarycare.org, and all of this content is available to download from there. All right, so you're going to evaluate cognitive function through a combination of a MoCA test and then getting input from a family member. And the 3 questions that you're going to ask that observer are actually very similar to the 3 questions that you use to help to decide whether to do this full cognitive evaluation. So ideally, you've got the patient returning for this cognitive evaluation visit, and ideally they've got a family member or a close friend there who you can ask these 3 questions of. Repeating the same question 30 minutes later, very, very worrisome sign. losing the ability to do a complex task that they once found easy to do, like doing a complex recipe or hanging outdoor holiday lights or preparing documents for their taxes. Worrisome sign. Becoming disoriented in a familiar place, a place that they should know well. So not a new place getting disoriented, but a place that they've been to many times before. Very worrisome sign. Those 3 questions again are in the epic.phrase.cognitive checklist. Or you can use a fully validated 8-item form called the AD8. So if you want to go beyond just these 3 questions, there are 8 questions in this fully validated form called the AD8. And here's a little bit of what that looks like. Again, it's an 8-item tool to get input from an observer, which is available in the Smart Set, but you can also download it from many places around the web. So this was actually developed at Washington University in St. Louis. Very, very well validated. You can download it from our website, cognitionprimarycare.org, or just Google search it. You can find it as well. And this is an 8-item questions to ask the observer that are an alternative to just having these 3 questions for yourself handy. All right, and so here is that checklist again that shows that actually those 3 questions are at the bottom of the checklist. So you can either favorite the .phrase.cognitive checklist or find it in the Cognition Smart Set, or if you're at the VA, you can find it on our website, cognitionprimarycare.org. And so let's talk a little bit about the Montreal Cognitive Assessment, the MoCA test. This is by far the best validated tool for identifying mild cognitive impairment in the primary care setting. It's more sensitive than the mini mental status exam. The scoring is shown here, really highlighting that this is not like a sort of a super easy black and white test to do. There is definitely going to be some uncertainty. In the same way that if you do a hemoglobin A1C, there might be sort of a range of hemoglobin A1Cs, which make the diagnosis of diabetes a little bit sort of uncertain. And you're just so good to identify it, though, so that you can follow somebody carefully. You're going to, especially if you get that uncertain MoCA score, that's the really important place to incorporate family input, follow somebody over time, consider recommending full neuropsychological evaluation. So this is where you refer somebody for the full 2-hour battery of neuropsychological testing, which is a lot for somebody to go through. The access to that at UW Medicine is somewhat limited. They are somewhat backed up and overwhelmed. There can be a really long wait time to get into that, to getting evaluation like that. It is generally paid for by Medicare, but again, it's a pretty grueling process for patients to go through. But there are definitely going to be situations where either you're very uncertain and concerned, or the patient is very uncertain or concerned, in which doing that full neuropsychological evaluation is going to make sense. And but such an important point to make about when you do a MoCA test is to input the result into Epic in the behavioral medicine flow sheet right next to where you would input a PHQ-9 score. And so that's what that looks like here. So here's the behavioral health tab. So again, it's three items over from the PHQ-9, where it's just so essential to, once you've done a MoCA test, to try to input the numbers into this flow sheet to make it a result that you can easily find and track. So rather than just having it sort of floating as free text in your note, where it will easily sort of get lost in the chart, or simply or sending the paper form for scanning, where it'll get lost in the media tab, you really want to make this a test result that you can identify and find easily, and others can find easily and track by entering it as entering the numbers into the MoCA flow sheet. And so there's various options for doing that. It's not too different from entering PHQ-9 numbers from paper into the chart. It takes about 20 seconds. The medical assistant could do it if you ask them, but it's almost easier for you to do it. You probably will spend less time just doing it yourself than asking the MA to do it. Whatever works best for you or your clinic, but most important is to try to get done, just because this has such high value. And it's still best practice to have that paper form where people sort of drew their clock and drew their intersecting diagram, scan that piece of paper into their chart as well. So I want to spend a moment talking about the difference between delirium and dementia, and how important it is to keep in mind that a MoCA test is just not very accurate in detecting cognitive impairment during or soon after an acute illness. That it is absolutely normal for there to be a transient drop in cognition in the elderly when they have an acute illness, and that is delirium. It's not dementia. And it's really important that, especially after a severe acute illness, such as one that required hospitalization, that impairment of their cognition, that delirium, can actually persist for weeks. And so it's really important to not try to diagnose mild cognitive impairment or dementia during or in the weeks following an acute illness. That said, if somebody does develop delirium during an acute illness like that, that is an important warning sign to notice, because their odds of dementia, either present now or developing in the next 1 to 2 years, is much, much higher if they have developed delirium during an acute illness. So it's not something that you're going to completely sort of disregard, but you just want to be careful and aware that you're not necessarily going to want to do this cognitive evaluation to try to make this diagnosis during or soon after an acute illness. So let's put it all together. So you're going to be doing your MoCA test. You're going to be gathering input from a family member or a close friend. And maybe you're going to find that their MoCA score is very low. It's less than 20. And maybe the observer is going to sort of say, yes, they are asking the same question 30 minutes later and forgetting that they even asked the question before, a worrisome change. And you might also find that they are starting to have difficulty with their activities of daily living. So they're not able to sort of cook as well. They're not able to clean their house as well. They're not able to get dressed as well. They're becoming somewhat dependent in their activities of daily living. And that is a diagnosis of dementia. So you do not need a neurologist to make this diagnosis. We in internal medicine should be able to make this very, very common and very important diagnosis of dementia, especially in this scenario where somebody has a low MoCA score, an observer is noticing changes in their cognition, and they're having difficulty with activities of daily living. That is a diagnosis of dementia. But what about a situation where somebody's MoCA score is intermediate? So perhaps they get a score between 22 and 26. But the observer is noticing worrisome changes, like, yes, they are asking the same question 30 minutes later, or yes, they really are getting stuck doing a complex task, like doing a complex recipe, or yes, I did notice that we went to the store in a place that they should know well, and they really sort of seemed disoriented and weren't sure which way to turn. But they are still fully independent in their activities of daily living. So they're still able to dress themselves and cook and clean their house. So that is a diagnosis of mild cognitive impairment. It's not a diagnosis of dementia, but it is still an incredibly important diagnosis to make of mild cognitive impairment. And so let's talk a little bit about what is mild cognitive impairment. And again, that typical case is somebody who has an intermediate MoCA score. It's low, but not terribly low. And an observer, a family member, or a close friend is noticing worrisome changes, but their activities of daily living are intact. That is mild cognitive impairment. It is different from dementia, which requires a loss of independence with their activities of daily living. And the reason why this is a really important diagnosis to make in distinction from early dementia is it's not simply early dementia, because about 30% of people with mild cognitive impairment do not progress to dementia. I have had this experience many times in my 20 years of primary care, where I've identified somebody with mild cognitive impairment, really thinking, aha, this is early Alzheimer's disease. But following them for 2, 4, 6, 5, 8 years later, they're cognitive impairment is exactly the same 8 years later as it was 8 years before. So this is not necessarily a progressive neurocognitive condition, that mild cognitive impairment. About 30% of people with mild cognitive impairment don't progress to dementia. That said, though, about 70% of them do progress over time. And it is the case that most people who have mild cognitive impairment do actually have early Alzheimer's disease, but not all. But this is such an important diagnosis to still make, that mild cognitive impairment can be a hook for you to take action, to focus on their brain health, to reduce their to encourage them to reduce their alcohol intake, to get their hearing tested or wear their hearing aids if they have hearing impairment, to test them for sleep apnea if they have signs of sleep apnea, or really encourage them to sort of use their CPAP if they have a diagnosis of sleep apnea, because those are all interventions that have been proven to improve in cognitive function in people, especially over age 65. And you're going to want to then also be careful about repeating a yearly evaluation to see if over the course of time that mild cognitive impairment does progress and really start looking more like Alzheimer's disease or dementia. And so at the end of that cognitive evaluation, you're going to be sort of in any one of these three main situations. It might be that their cognitive evaluation looks okay, in which case you're going to want to discuss ways to keep their brain healthy, the things that that checklist that we just talked about, consider repeat evaluation in 12 months. If you have identified these contributing factors, really talking to them about decreasing their alcohol intake, increasing their exercise, using their hearing aids, treating sleep apnea, treating depression. But if you've made a new diagnosis of mild cognitive impairment or dementia, it's so important to have a really key phrase handy, because you're not going to have time to do a good job of counseling them about that new diagnosis right then and there. You're going to want to have a phrase ready like, gee, this is a lot to take in and work through. I would really like to schedule another appointment soon to review what this means and make a plan. Strongly consider trying to have that be a longer slot appointment again. Strongly encourage a family member or close friend to attend that visit with you. Just so important to not get into the rut or the pitfall of diagnosis and adios. Don't diagnose and adios. If you make this diagnosis, so important to be ready to schedule a follow-up visit where you can really adequately counsel them and make a plan for that diagnosis. So takeaway so far is, is that we can do cognitive evaluations in primary care. So important to have a family member or close friend input, essential for that evaluation. Combine the MOCA test with a family friend interview. Consider using an 88 form for gathering that observer input. And really addressing brain health, key modifiable causes of mild cognitive impairment are so important to be aware of and make a difference with. All right, so now we're going to move on to part 2 of the talk, which is setting a plan for the newly diagnosed patient. So back to our case, that 82-year-old woman. So it turns out that her MOCA score is pretty low, but she is still fully independent with her activities of daily living. And so you've made a diagnosis in her of mild cognitive impairment. And so let's set a plan for the newly diagnosed patient. We're going to talk about what words to use in the diagnosis. We're going to talk about how to talk about prognosis. We're going to talk about when it's absolutely essential to refer somebody to a specialist. And we're going to talk about high-value community resources that you can recommend. So at the end of that evaluation, diagnosis was mild cognitive impairment, and you were ready to sort of tell her, gee, this is a lot to take in and work through. I'd really like to schedule another visit soon to review what this means and make a plan. So here she is, she's returned for that follow-up visit. You have been smart and able to schedule it into a long slot appointment, sort of hoping that that is easily accessible in your clinic setting. And again, you've encouraged a family member or close friend to attend that visit. And here's a checklist of what you're going to cover in that visit. You're going to talk about disclosing and prognosing. You're going to talk about when it's absolutely essential to refer to a neurologist or another specialist, talking about brain health, talking about caregiver support and resources, and talk about what the follow-up plan for that visit will be. So let's start talking about disclosing and disclosing the diagnosis and talking about prognosis. Because this is really going to be the number one thing that's on everybody's mind. They've come to this visit, they're concerned. And this is really so similar to sort of general delivering bad news training. So you really want to try to not have the patient there by themselves. You want to really try to have either a family member or a close friend there. You're going to want to set the stage. You want to ask first, is it okay if I share what I think is going on? And, this really preps them for the bad news. In effect, you're asking sort of, are you ready for us to talk about this really serious thing now? You want to acknowledge that it's scary, but you also want to share some optimism and really sort of try to sort of frame this as something that is so good that we've identified. It will really help us to sort of improve your care and be ready for what is to come. And so here you really want to think about what terms to use when disclosing the diagnosis. And here words matter a lot because many people have, if the diagnosis is mild cognitive impairment, many people have never heard that term before. Many people have never heard of mild cognitive impairment before. And so you want to be careful to not just use that term because that can really falsely reassure people in some ways. They can walk away from that visit saying, phew, thank goodness I don't have Alzheimer's disease, when actually it is quite possible and maybe even likely that they do have early stage Alzheimer's disease. But you also don't want to scare people too much. So if it is mild cognitive impairment, you really do want to share with somebody that there's a 30% chance that 6 to 8 years from now, your brain might be exactly the same as it is now. But you also do want to use the word possible early Alzheimer's disease. You want to say something like, I'm worried that there is a high chance that you have early Alzheimer's disease. And so it's so important for us to watch this closely and look at some changes that we can make to promote your brain health, to keep your brain healthy. There are ways that we can help. But if this does get worse, don't worry, it happens very, very slowly, and you will be there to support them through that. So you want to say, if it's mild cognitive impairment, there is a 30% chance that 6 to 8 years from now, you could be exactly the same. If the diagnosis is dementia, you then also do want to provide some degree of reassurance that the timeline to progression is very, very slow. It's hard to predict. It could be 6 years, it could be 10 years, it could be 12 years before they reach that stage of advanced dementia. And so you do want to reassure them that you will be very near to where you are now for several years to come. And you really, again, want to give support. You want to say something like, I'm going to be here with you. We're hoping for the best, but I'm here to help if things get worse. And it's so good that we have your family here to support, to help. And you want to have some great phrases to use for this newly diagnosed patient. Things like, living with memory loss is not easy, but I'm going to help you live well. We're going to focus on keeping your brain healthy, to think more clearly and find ways to still enjoy life, and that you're not going to be walking this path alone. Your family, your friends, and me are here with you as we move forward. All right, and now we're going to talk about referring to neurology.
Brock,
Yes,
before doing so, there's a couple of questions that have come up in the chat.
Yes.
So Clinton asked, how would you go about documenting the results from the cognitive assessment appointment in your note without preemptively giving away the diagnosis to the patient? I presume this means before you've had that appointment, and in the era, I suppose, of open notes and people seeing charts and such.
And so it's not so much that you're hiding the diagnosis from them. And if they do read that diagnosis in their note later, it's okay. I mean, it's not wrong to sort of say the diagnosis at the end of that cognitive evaluation visit. So I wouldn't say that you're hiding it, but what you do want to say, this is a lot to take in, and I just want to really be sort of careful and sure that we're going to follow up soon so that we have enough time to sort of fully counsel about it and fully make a plan for it. So, right, it's a good point, Clinton. It's not that you're sort of hiding that or not disclosing the diagnosis at that point, but you want to be careful to say, I want to assure you that this is a lot to take in, and I really want to follow up an appointment soon so that we can fully sort of talk about it.
And then Gina asks a question, which I think is a good one, which is, I'm curious how you factor certain things into MoCA score, having to do MoCA through an interpreter with non-English
Yeah,
speaking patients. So for example, words that start with F in 1 minute may be
absolutely.
challenging. Patient education level impact and patient
Yeah,
culture.
extremely hard. And there's no easy answer to that. And I think, all the time, even if you send a patient who's non-English speaking to the Memory Brain Wellness Center to see a neurologist, a dementia expert, they will they will have difficulty sort of doing that assessment in as accurate way. It's just really, really hard. And so in that situation, MoCA is available in many, many languages that you can download from the website mocatest.org. But also in a situation like that, you might rely a lot more on observer input, like a family member or a close friend, than you might a MoCA score. And you're just going to try to sort of factor that into a MoCA score, that it may not have sort of gone as well in a non-English speaking person.
And then there's a follow-up question from someone else. What are your thoughts on using the RUDAS for non-English speaking patients?
Yeah,
It's
and so
not a tool I know.
yeah, so I mean, there are many tools, assessment tools out there other than the MoCA, and the RUDIS is one of them, which was developed in Australia, that has been tested some in people who are in Aboriginal cultures in Australia, and so it's a perfectly sort of reasonable alternative to consider. I will tell you that it is not nearly as well validated in the primary care setting as the MoCA test is, but there's nothing wrong with the RUDIS at all.
Great, thank you.
Any other questions for right now? All right. So let's move on to when to refer somebody, when it is actually essential to refer somebody to a neurologist, because it's never wrong to refer somebody to a specialist, such as the Memory Brain Wellness Center at Harborview, a neurologist or some other a specialist. And for sure, if a patient is sort of like, you're getting the sense that they really, really want to see a specialist, absolutely appropriate and okay to refer them. But you do want to keep in mind of the situations where it's really essential for them to see a specialist. And this is a shared decision making with patients. It's really okay to hold off on a referral if there's no big red flag. So the big red flags are somebody who's having atypical neurologic symptoms in addition to cognitive impairment. So if somebody is sort of developing unsteadiness in gait, in which case you might be worried about normal pressure hydrocephalus or Parkinson-like symptoms, really important for them to see a neurologist. Anybody who's developing progressive cognitive impairment before age 65, this is extremely unusual. This is not typical Alzheimer's disease at all. That person absolutely needs to see a specialist. But for many cases, it really is okay to work somebody up and follow them over time to build trust with the patient and families. But you really should be aware of atypical dementia symptoms that are absolutely important and could be a reason to very strongly encourage a referral right away. And that is Lewy body dementia. So somebody who is having visual hallucinations together with their cognitive impairment does potentially have Lewy body dementia, and that is much less common than Alzheimer's disease, but is a really important diagnosis to be aware of, and it's not an easy diagnosis to make. And so I would definitely not recommend trying to make that diagnosis in the internal medicine setting. That somebody who has visual hallucinations, who very well might have Lewy body dementia, really needs to see a specialist. And the main reason that is such an important diagnosis to make is it really has important implications for their long-term management. If they can somebody with Lewy body dementia is at much higher risk of severe adverse reactions to antipsychotics. It can cause severe and potentially irreversible Parkinson-like symptoms if somebody with Lewy body dementia gets an antipsychotic. And so visual hallucinations is an absolute sort of must for referring somebody to a specialist, and that's why we put that question in that cognitive evaluation checklist. By far the most common type of dementia is Alzheimer's disease, in which memory loss, especially short-term memory loss, is the main symptom. Vascular dementia is a really sort of tricky condition to really figure out, because it is almost always mixed with Alzheimer's disease. That it's a relatively unusual situation in which somebody has completely isolated just sort of small vessel disease, vascular dementia. It certainly can occur, but vascular dementia is much more commonly in combination with Alzheimer's disease. And I will tell you that actually there are really good studies now where they do autopsies of people's brains who had dementia after they died, and they try to correlate what their brain tissue looked like after death with what their pre-death diagnosis was. And there's a lot less correlation than we might sort of want there to be. That there is just a lot more overlap. It is much more likely that most people with dementia have a mixed form of dementia, in which they might have some plaques and tangles of Alzheimer's disease. They might have some small vessel infarctions of vascular disease. Heck, they might even have some Lewy bodies sort of sprinkled in there. They might have changes in their frontotemporal areas of their brain, like frontotemporal dementia. The bottom line is that types of dementia is a very fuzzy and mixed picture most of the time, but it is just so important to be aware of the presence of visual hallucinations as a very, very high impact reason to refer somebody to a specialist. And so, like I said, visual hallucinations just definitely raises the question of Lewy body disease. It's often a complex determination. Like I said, it has major treatment implications. And so just really anybody with visual hallucinations who is also having cognitive impairment should be referred to a specialist. And you can find that visual hallucination reminder on the dot phrase cognitive checklist. So a really hard question that I get asked all the time is, does everybody need brain imaging? And I would say, yes, probably. I mean, I think most patients who develop cognitive impairment really should have at least a non-contrast CT of their brain. It's a relatively low cost, low risk thing to do. 20 years ago, it was a different issue where CT scans were much more difficult to get and much more expensive to get. These days, it's really hard to walk into an emergency room if you're over age 65 and not have your head scanned. So I would say that really pretty much everybody with cognitive impairment should get some form of brain imaging. For sure, if somebody is having urinary symptoms or gait symptoms where you might be concerned about normal pressure hydrocephalus, they absolutely need imaging. The question of what kind of imaging, so should it be a non-contrast CT, should it be an MRI, is a little bit sort of unclear. There's not really super strong consensus as to whether one is better than the other. If you're going to be referring somebody right away to a specialist, it's actually okay to hold off on imaging, because that specialist is going to probably select the imaging modality that they want to have. But even in that situation, it's not wrong to get a non-contrast head CT. All right, now we're going to talk about promoting somebody's brain health after a diagnosis of mild cognitive impairment or dementia. And here, it's the same kinds of things that you are thinking about as you are evaluating their cognition. These are all things that have been shown to improve cognition, even people who don't have mild cognitive impairment or dementia, but especially in somebody who has mild cognitive impairment or dementia, telling them that reducing their alcohol intake, that avoiding medications that are sedating or anticholinergic, that wearing CPAP, wearing hearing aids, taking a brisk walk with a friend, staying socially engaged, and eating a healthy diet, maybe a Mediterranean style diet, are all good things to recommend that really do promote brain health. And that there's a one-pager that describes all of this in the Cognition Smart Set. So now let's talk about caregiver support and resources. And here, the number one resource that I would recommend is called Powerful Tools for Caregiving. It's a free 6-week class that is designed to help care partners take care of themselves while they are taking care of a loved one. The website is powerfultoolsforcaregivers.org. There are many instances of this being offered for free in the Puget Sound area. And if you go to our website, cognitionprimarycare.org, there is a tab called Community Resources, where we identify that as well as other really important resources to offer to a family who is facing a new diagnosis of cognitive impairment. And so follow-up is the most important, that, again, really avoiding the diagnosis and adios phenomenon, that you're going to really want to make sure that you are sort of there and sort of following people and just sort of not leaving them adrift with this new diagnosis. That really you're going to want to keep scheduling them for return visits until you have really sort of worked through all of the items on that cognitive checklist to maintain their brain health. You may not get to all of them at that first visit. And so having them come back in a month or two to keep working down that checklist is really important. And then to maybe see them back 6 months later or 12 months later. We're going to talk later about advanced care planning, how important it is to address their durable power of attorney while they still have capacity. And then we're going to talk about considering medications for cognitive decline. And that's a key topic that we're going to get to next, that you're not necessarily going to sort of try to tackle at that very first counseling visit, because there's so much to talk about, but those are the things that will happen at that follow-up visit. But so the takeaways again for this last part were, even if the diagnosis is mild cognitive impairment, it is important to mention your high concern for Alzheimer's disease so people don't walk away falsely reassured. You do want to include some optimism and some support that people can live well for many, many years, even after a diagnosis of cognitive impairment. And if there is cognitive impairment, especially mild cognitive impairment, there's actually some prognostic uncertainty that this may not progressively develop into dementia. If somebody has visual hallucinations, it's so important to refer them to a specialist and to provide resources and to make a clear follow-up plan. All right, so I was thinking now it would be a good time to take a short break, to step away for 5 minutes if you'd like. Also a good time to take more questions if you'd like. But in our next section, we're going to talk about medications for cognitive decline. We're going to talk about managing agitation and other behavioral symptoms of dementia, communication tips when talking to someone with dementia, and then talking about advanced care planning specifically about dementia. All right, so we will resume at the top of the hour at 10 o'clock, but also during this time, also happy to take more questions if you've got them.
Brock, can I ask a question? So these resources, what are your suggestions for people who are truly isolated, who don't have family close by? Do you have other resources or other ideas for those folks?
Yeah, so hard. And I mean, they're, one of the best places to often find programs for somebody like that is at like a senior center. And so, there are various senior centers around the Puget Sound region. The one that I think is like the most highly advanced for this is in the Greenwood neighborhood. Greenwood Senior Center has an amazing set of programs for people, especially those who are isolated. But this, in the same way that somebody who is non-English speaking is especially challenging, somebody who is truly isolated is extra challenging. And there, if you have any access to a social worker, that's the time to do that. And that also might be, more reason to try to refer somebody to a specialist, because a specialist clinic like the Memory Brain Wellness Center at Harborview will have a social worker associated with that clinic who is especially good at helping people with cognitive impairment. But even with somebody who is isolated like that, you're also going to have more difficulty getting them to that specialist referral. And so really, if you have any social work resources at the clinic where you work, that would be probably one of the best places to turn to.
Cool. No other questions have come up, so we'll see you back in 5 minutes.
Great. And I'm happy to stay on. If anybody does want to unmute and ask a question, feel free. All right. Welcome back, everybody. We're going to get started again. Give people another minute to get back with us. And we are in the home stretch. All right, so let's move on to the final part of the talk, which is really all about managing dementia as it progresses. And just here, it's just so important to not just get good at identifying dementia without really feeling confident in what you're going to do to help manage it as it progresses. And so I want to start talking a little bit about medications to treat dementia, because this is definitely, one of the things that patients and families are going to ask about the most, and something that is difficult to really wrap your head around. What does the data really show? And it is definitely reasonable to eventually offer a medicine like donepezil or memantine to somebody with dementia, because they are safe and they're easy to prescribe. But it is so important to just like have clear in your mind, and to be able to share with patients and families as well, that these medicines may result in small improvements in some people. So they might slow the loss of function a little bit, but these are really best thought of as symptomatic therapies that are not neuroprotective. They don't change the trajectory of the disease. These are not disease-modifying treatments. And they do not work for early stage impairment. So they have been tested very, very carefully in people with mild cognitive impairment who are still fully independent with their activities of daily living and have not been any different than placebo. And so it's just so important that this is not the kind of like, oh my God, we've got to immediately get you started on this medicine in order to sort of save your brain cells. It just, the medicines don't work that way. And so I really would sort of, there's so many other things that we just talked about that you're going to cover in that that newly diagnosed counseling session, where these medicines shouldn't be part of that. They should eventually be something that you might offer and discuss, but at the outset, this is a relatively low priority. The newer medicine that is FDA approved, which was approved last year, is aducanumab, which is a monoclonal antibody against amyloid plaque, which is the first FDA approved medicine in this sort of holy grail quest to find a disease modifying treatment. And it's true that it was FDA approved, but in a very, very controversial way. So after it was FDA approved, CMS Medicare actually ended up severely limiting its availability to only patients who are enrolled in a clinical trial, mainly because its cost is incredibly high, and the efficacy that the FDA based its approval on is actually very, very weak. That efficacy is extremely controversial. It's really unclear if there is a clinical benefit as opposed to a surrogate marker benefit. And it's actually kind of shocking that the advisory panel to the FDA voted 10-0 against approving it. And there was just so much pressure on the FDA in other controversial ways that they still went ahead and approved it, that it's still kind of hanging in a little bit of limbo from a clinical perspective. It's a once a month IV infusion that really we would think of somebody sort of being on indefinitely. And there is definitely significant risk from this medicine in terms of causing brain edema or microhemorrhage in the brain. And so for this reason, this is definitely not a primary care medicine to prescribe. And it's even a little bit fuzzy as to how much this should really factor into our kind of impetus to refer somebody to a specialist. It's important to know about it. It's important if somebody is sort of aware of it and curious and wants to potentially pursue it, that's a great reason to refer somebody right away to see a specialist. But keep in mind that this was FDA approved in a very controversial way because it has somewhat uncertain clinical benefit as opposed to surrogate marker benefit. But now let's talk about really what is, in a way, the most challenging part of managing dementia, which is the behavioral and psychological symptoms that people very commonly get. It's very common that at some point in the course of a dementia illness, people with dementia can become agitated, they can become paranoid, they can have sort of episodes of yelling, especially like in the middle of the night, They can possibly be even hitting their care partners, which is incredibly difficult for everybody involved. This is a really common thing that does happen at some point in the disease. The very first thing you want to do is, again, be looking carefully at their medication list, because medicines that are anticholinergic like oxybutynin can make symptoms like that worse. Even a sedating medicine like zolpidem or Ambien can have a weirdly idiosyncratic effect of making symptoms like that worse. And benzodiazepines especially can potentially make those symptoms worse. And so whereas we might be really tempted to use a benzodiazepine sort of to help to treat this agitation, because it's so effective in a situation where, say, somebody has agitation, say from alcohol withdrawal, we might be tempted to use benzodiazepines in this situation when somebody has agitation related to dementia. But benzodiazepines can really make those symptoms worse in an idiosyncratic way. Really important to use benzodiazepines with extreme caution in somebody who has dementia. And so really, it's sort of your first line and second line and third line and fourth line approaches to treating those symptoms are non-pharmacological approaches. Like, these are behavioral strategies that have really been shown to help. So these are well-designed clinical trials of these interventions that are somewhat difficult to implement from your internal medicine clinic sort of standpoint. There's definitely somewhat of an art to these non-pharmacologic approaches. The book that is most commonly recommended in a situation like this for families is called The 36-Hour Day. And I would also point you to our website, cognitionprimarycare.org, that has a handout with useful tips for communication. The main thing that is really important to focus on is really de-escalating a situation where somebody is becoming agitated, that there are distracting and sort of calming maneuvers that care partners can take to really help to sort of distract people or to de-escalate an agitation situation that is really that are effective and really are so much more important to focus on as first, second, third, and fourth line before turning to a medication. And so here are some of the ways to think about how to de-escalate a situation like that, how to talk to somebody with dementia. You want to first make sure that you're talking directly to them and not about them as if they weren't there, because somebody may not fully understand what you're saying, but they might very well pick up on the idea that you are talking about them. And that really can be agitating. And you can avoid distress by speaking directly to somebody in sort of a very calm and non-threatening way. If somebody becomes agitated and aggressive, there's a natural reflex to sort of meet aggression with aggression. And it's just so important to stay calm, perhaps even to withdraw from the situation, to not be stern. The moment can often pass. And if that agitation isn't met with sort of sternness, it really can often de-escalate the situation. Meeting people where they are is just so important. Like, avoiding correcting somebody to try to bring them back to reality is such an important communication tip. It's not necessarily intuitive. If somebody starts talking about their sort of dead spouse as if they are still living and are, about to come visit, it can be tempting to try to correct them. But really, correcting somebody in that situation is so much more likely to cause agitation and alarm than it is to help to sort of ground them in sort of the truth. And it really doesn't help. And they're going to quickly forget whatever correction you tried to give them. Instead, really changing the subject, engaging in a relating topic. And there's a really good handout that we have for families on that, which covers this approach, which is available on the website, cognitionprimarycare.org, or recommending a book such as The 36-Hour Day is a really important and useful non-pharmacologic approach to treating these behavioral symptoms of dementia. But sometimes those don't work. Sometimes somebody is having really severe agitation where the situation is really reaching a crisis point where, somebody is sort of putting others around them in harm's way. If you've tried these non-pharmacologic approaches and somebody is still extremely agitated, severely so, then it is reasonable to think of using a pharmacologic approach to treating those symptoms. But it's just so important to not have those be the first line approach. They need to be the fourth or fifth line approach, mainly because those medicines can cause severe sedation. That one of the biggest harms of medicines like this is that they can extremely sedate somebody and impair their cognition. But you might sometimes need to use them, in which case using a very low dose of quetiapine or a very low dose of risperidone is a perfectly reasonable thing to do in a severe situation like this. These are much lower doses than we would ever use for something like schizophrenia. It's really important to think about using these medicines in a scheduled way rather than an as needed way, once daily in the evening. And the main reason to do that is that these symptoms are often transient. And so if you sort of use them PRN at the very first signs of agitation, you might over treat somebody, you might over sedate somebody, whereas, might have been that 30 minutes later, that agitation may have passed, and that by the time they get that medicine and that medicine is taking effect, it might be unnecessarily sedating them. So these medicines work much better in a scheduled way, only when severely needed, in which case you are going to use them in a scheduled once daily, every evening way. They just don't work fast enough yet to use PRN. And you might need to titrate the dose up every 3 days, but you actually might not need to. These medicines are so sedating that often this very low starting dose is really all that somebody needs. And really the biggest pitfall of using an antipsychotic in this setting is leaving them on for too long, because behaviors do eventually improve. So as dementia progresses, it's not necessarily that somebody is going to stay agitated like that for the rest of the course of their disease. As dementia progresses, the agitation type symptoms like this do often just lessen on their own. And so it's really important to schedule a taper off of a medication like this after 3 months, because somebody might not need them long term. It might very well be that if you taper them off after 3 months, those symptoms return in a severe way, in which case it's reasonable to restart them. But really important to not sort of leave somebody on a medicine like this forever, because you really can sort of turn them into a zombie unnecessarily by overly sedating them and impairing their cognition. And don't forget about the very strong warning that somebody who has Lewy body disease is at very high risk of developing severe Parkinsonism from an antipsychotic. So it's not to say that a geriatric psychiatrist might not end up recommending or using an antipsychotic in somebody with Lewy body disease, but you really do need to have that specialist input in a situation like that, because of what a high risk situation that is. All right. So before we turn to advanced care planning for dementia, I did want to stop for a moment if anybody had a question.
Yeah, I have a question specifically about Geri Psych, where I feel like at the VA, there's some Geri Psych access, but just broadly speaking in the UW system, psych access, generally speaking, is really hard. Do you feel like if you feel like someone needs a geriatric psychiatrist, the best way to do that is through memory clinic, or is through encourage them to find someone in the community based, or kind of what is your experience with that?
Yeah. So hard, and there is just no easy answer. I think that that the geriatric psychiatrists in the UW medicine system are mostly centered at the Memory, Brain, and Wellness Center at Harborview. So that's a really important and useful reason to refer somebody there. you're not necessarily going to have quick sort of the kind of quick urgent access that you're going to want. And so this is just a very, very sort of tricky situation. I think, there is a geriatrics clinic at Harborview. There is a psychiatry clinic, but neither of those have great access, but aren't wrong to consider trying to get somebody into. But probably it's the Memory Brain Wellness Center where you'll have the best luck getting a neuropsychiatrist to help. The community is really, really challenging. I think, so somebody who lives in a memory care facility will often have, they will often have somebody contracted with them who they can work with. But for a community sort of dwelling person who's having severe symptoms like this, it is definitely challenging to especially get urgent access to a neuropsychiatrist. And, but that's another reason why somebody who you're worried about possible Lewy body dementia really should be sort of referred right away, because if that person is sort of established at the Memory Brain Wellness Center early, then treating symptoms like that, which are much more sort of complicated to treat, they will have better and easier access to a neuropsychiatrist there, a geropsychiatrist. All right, so now let's turn to the final topic, which is advanced care planning for dementia, which is really all about helping to align the medical care that people get with the medical care that they would have wanted. And so on one hand, you might first think of like, oh, well, isn't this like the standard advanced directive that you just want to make sure that everybody sort of fills out? And it's really, really interesting if you actually read what's in the standard advanced directive. It really gives almost no guidance about what somebody would want if they developed dementia. That the main focus of the standard advanced directive is if I'm in a permanent coma, or if I'm in a persistent vegetative state, or if I am in a imminently terminal condition, a soon to be terminal condition, this is what I would want. But it really gives almost no guidance on the number one reason that people lose decision-making capacity, which is dementia. And so for that reason, I have worked with other people here at the U in the Cambria Palliative Care Center, and in the geriatrics division, and in the neurology department to really develop a dementia-specific advanced dementia directive, which has been tested and refined in primary care, and is available for anyone to download from the website dementiadirective.org. And so at that website, dementiadirective.org, you can download a dementia-specific advanced directive, which is structured as giving brief descriptions about what mild dementia is often like, what moderate dementia is often like, and what severe dementia is often like. And then below each of those descriptions, it gives people the ability to choose a goals of care option for what they would want at that stage. So here's a screenshot of what that website looks like, dementiadirective.org. And the best time to offer a directive like that is actually before signs of cognitive impairment occur. I really would strongly encourage it for anyone who's over age 65. And part of the reason for that is when I first started testing this among my own patients, I thought that the most important time to offer it to somebody was in that very early mild cognitive impairment stage, where I'm much more worried that they're going to develop dementia in the future. And so I would sort of bring this out and I would talk to them about it. I would show it to them. And I would often get like oh, this is great. Thank you. I'll take it home and think about it. And then I would see them back sort of 3 months later, 6 months later, a year later, even 2 years later. And even with sort of reminders, I found that almost nobody with mild cognitive impairment was filling it out. And at first I thought it was like, oh, they're just sort of so in shock by the diagnosis at first that it's like difficult, but eventually they'll sort of get to it. But really over a year or two, when they are becoming much more sort of psychologically sort of accustomed to the idea that they have mild cognitive impairment and might be developing Alzheimer's, it still was very, very difficult for them to fill this form out. And I started realizing that it may be not just a psychological barrier, but it might be actually a physiologic barrier, that one of the very first things that people lose when they are developing mild cognitive impairment is the ability to imagine a future state of themselves. Like that's a cognitive function that we relatively take for granted. We don't think of it necessarily as a high level cognitive function, but that sort of planning for the future, that imagining a future state is actually can be very, very difficult for somebody with mild cognitive impairment. And so instead of offering it to people with mild cognitive impairment, I started offering it to all of my patients over age 65. And instead of getting almost nobody filling it out, I started getting almost everybody filling it out, because this really is a topic that a lot of people think about and worry about and have a wish to express their preferences a lot. And so I really would recommend it for people before they develop mild cognitive impairment. But what about when people do have that early stage dementia, or when they have mild cognitive impairment? There, by far, the most important thing to do in terms of advanced care planning is to make sure that they have a well-established, durable power of attorney to set their proxy decision makers. And so on one hand, you might think, gee, most people don't necessarily need to have that form filled out, because the person who would be by default be their durable power of attorney, their proxy decision maker, is relatively sort of clear cut. It's usually their spouse. But the problem is that dementia is such a long disease that the horizon for the progression of dementia is 10 to 15 years. And so it's really very possible that their default surrogate decision maker, usually their spouse, may no longer be available to serve as their decision maker late in the course of their disease. And so early, it is so important to designate in a legal form who they would want the backup to their default person to be, who they would want the alternate to their spouse to be, because that very well might be a close friend who might have no legal standing whatsoever if their spouse isn't available to serve in that function. And I would also really, really highly highlight the importance of a POLST form, especially as dementia progresses. So not necessarily, I think that the highest priority form to fill out in early stage cognitive impairment is the durable power of attorney form. But as dementia then progresses, the POLST form, the portable order for life-sustaining treatment, is incredibly useful. It's a really crucial tool to anchor a goals of care conversation and really to provide that communication across care sites. And so even though somebody's POLST form was mostly initially designed to be for use if somebody calls 911 and the medics rush into their house, to sort of give the medics the legal sort of coverage that they don't necessarily have to resuscitate somebody who's in cardiac arrest in their home. That was the initial impetus for developing the POLST form. But really, I would say that the even much more important sort of practical usefulness of a POLST form is as a conversation tool that can be portable, that can travel with them from care site to care site, where you still are going to need to reaffirm what their code status is. So that POLST form is not that from home is not necessarily going to be operational when they hit the emergency room or when they are sort of admitted to a memory care facility. But it is so useful as a communication tool to carry forward the results of the conversation that was had before, so that that goals of care conversation that occurs in the new care setting is not sort of starting from scratch, but can start from like, oh, here's the pulse form that I filled out earlier. And these are sort of, this is the conversation, the results of the conversation that we had before. And it can make that goals of care conversation so much more sort of practically useful if that pulse form has been filled out. And again, this is for setting the goals of care now. So what if my heart were to stop now? Or what if I can't breathe on my own now? Is the preference for comfort focused care only? Is it for ICU care? Is it for full life prolonging care? A pulse form is really such a useful anchor when somebody is developing advanced dementia to make sure that that goals of those goals of care can be better honored. And it's so important to remember the why for why these different levels of intervention might be chosen. This is the case for both the dementia directive and for a pulse form. In both situations, these decisions and these preferences are really, really specific for dementia in a way that that is important to discuss with people, because if somebody has cognitive impairment, so if they have mild cognitive impairment or dementia, and they have something catastrophic happen, like a cardiac arrest or a severe pneumonia that requires them to be intubated in the ICU, even if they were to survive an intervention like that, they would be at much higher risk of being in a much worsened state, even if they were to survive. And that might be a reason why somebody might say, gee, no CPR, no intubation in a setting of mild cognitive impairment or dementia. Somebody similarly might have as a preference comfort-focused care in that setting, focusing on symptom relief only, because of the much higher risks of adverse effects, of agitation, more complications from many interventions in somebody who has mild cognitive impairment or dementia. And here it's a really useful phrase to use when having a goals of care conversation like this with a family member is, imagine if your loved one could look down on themselves now, what might they say that they would want? All right, so key points of this last section are really that donepezil or memantine are safe, they're easy to offer, but are of relatively modest benefit, not effective for people with mild cognitive impairment, that behavioral psychological symptoms should be treated with non-pharmacological approaches if at all possible, use antipsychotics only when symptoms are severe and those non-pharmacological approaches are not working. Don't use antipsychotics as needed. They are much, much more effective and safely used in a sort of nightly scheduled way. If needed, you can titrate the dose up every 3 days, but start at very, very low dosage and make sure that you are scheduling a taper of them for off at, say, the 3 or 6 month mark. If Lewy body disease, remember the major caution of using antipsychotics because they can cause severe Parkinsonism. And for advanced care planning for dementia, to think about before cognitive impairment occurs, offering a dementia directive to everyone over age 65. If somebody has mild cognitive impairment, so important to have filling out a durable power of attorney for healthcare proxy document to identify who the alternates that they would want to their spouse as soon as possible while they still have capacity to fill a form like that out. If somebody has moderate to severe dementia, a pulse form is incredibly appropriate and valuable as a communication tool that can be portable from care setting to care setting. And a key phrase to use when having a goals of care conversation with a family member is, imagine if your loved one could look down on themselves now, what might they say that they would want? All right, so that is the end of our presentation on dementia evaluation and management. Don't forget you can download free summary tools from the website cognitionprimarycare.org, and it looks like we do have time for questions. So thank you all for joining.
Thank you so much, Brock, for being here and sharing all this. I had another meeting, so hopped on late, but I was wondering, I was at that first session of the cognition in primary care series, and I know there were the dot phrases. Did you share those with this group already?
I did, yeah.
Okay, awesome, cool.
Yeah.
Just wanted to
Yeah.
make sure.
Yeah, and but then I felt bad that I forgot about the VA folks who don't have access to those. And so, but then I think, Gina put in the chat that, it is really, really easy to copy and paste and steal them and use them at the VA as well.
Great, good. All right, looks like we have a question in the chat from Lauren. In situations where the DPOA's preference differs from the pulse, what takes precedence? Not sure if this happens often.
Yeah, great question. And it does happen. I don't know, it's hard to say exactly how often it happens, but it definitely does happen. And it's important to be prepared for it when it does. In a situation like that, it is really, really important to keep in mind that from a legal perspective, it is the surrogate decision maker who is always sort of the operational guide. And so a pulse form, the legal standing of a pulse form is really in that home setting outside of a hospital or a nursing facility where a medic arrives, somebody's called 911, the legal standing is the pulse form really helps the medic to have the legal coverage to not resuscitate, to not shock somebody who's in cardiac arrest. But a pulse form that is used as a portable communication tool, so somebody who brings a pulse form to an emergency room, or a pulse form that you might find that somebody has scanned into somebody's electronic health record, is a communication guide, but is not legally binding in a hospital setting. There, it's really a goals of care conversation, a code status conversation with the surrogate is what is the guiding overriding principle. But that's not to say that if you then notice a lack of concordance between what the surrogate decision maker is saying and what you see in a pulse form, then that's just a really sort of like high impact, high value situation to be sort of aware of and think about that goals of care conversation with the surrogate, where you might sort of bring out the pulse form and try to sort of reconstruct what was the conversation that might have led to that pulse form being filled out, that might sort of have sort of good use in terms of what the goals of care conversation is at that point.
I'm not seeing other questions popping up.
Don't be shy. Anybody want to?
Yeah.
Feel free to unmute. This is we're a friendly, non-judgmental group.
If people are thinking about questions, I just wanted to say thank you for doing this talk. This is such important work. I think many of us who've been doing primary care will often admit to this being an area that often brings discomfort, even having done it. It's great to have an expert like yourself share your thoughts.
All right, thank you all so much for joining, and yeah, feel free to email me, or if you're at Roosevelt Clinic, ask me questions at Roosevelt, and these are tools that are freely available, and you should feel free to go to the website and check them out. And and regardless of where you practice, feel free to take these tools along with you. Really, my goal is to eventually try to roll training like this out to other health settings outside of UW medicine, and so you can help to spread the word as you go out into the world.